Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humour and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. Welcome back to the Dusty Muffins, the menopause podcast where we spill the tea, share the science, and keep it spicy.
That's right. Whether you're perimenopausal, postmenopausal, or just here for the juicy sexual medicine updates, you're in the right place.
Today, we're diving into the biggest takeaways from the ISWISH 2025 meeting. And trust me, folks, there's some wild history, scandalous ethics debates, and real game changers in women's sexual health.
And buckle up because we're covering everything from how sex was treated in ancient Greece, spoiler alert, women had zero rights, to the latest controversies in hormone therapy.
ISWISH 2025 was the annual meeting of the International Society for the Study of Women's Sexual Health. So let's get into it, shall we?
Woo. All right. So part two. I'm telling you guys, like, we've got thick notes here. This is how much stuff. Like, I can't even talk about this without my notes.
Rebecca did a lot of work to put these notes together. I don't know how she did it, but she has put together an agenda which is keeping us on track.
Focused. Sometimes we're like, squirrel.
I mean, it's keeping us focused to a certain extent.
Yeah, I know. It really was. So this was in Atlanta. This was my first one. I think all three of us. We're missing a muffin today because she is doing some amazing work on 2 lectures coming up. She's traveled over the last several weeks and is traveling again. And so we miss her and we hope we make her proud with the 2 of us here. So
we do. We miss you, Christine. We need our Dusty Muffin back.
We miss our third, our Charlie's Angels, right?
Yeah. Aaron's Angels.
Yes, Aaron's Angels. That's right. So So we were in Atlanta and this was the end of February. And so I believe it was a total of 5 days. We flew in, it was like a pre-course, but we started Thursday. So all day Thursday, all day Friday, all day Saturday. There was a couple lectures on Sunday, but I had to fly home. Mm-hmm. Did you end up going to any of those?
I caught the last bit of a podium one. Yeah.
Okay. And so it really was very intense. Again, we said this in the first podcast, but there was no downtime. I mean, it really was. We were learning all day long. Hence, abundant notes here.
Our brains were fried, basically. Absolutely fried.
We were just like, do we even want to go to dinner? Oh, I don't know. I can't even think. I can't even take pictures.
I know. All we did was want to take our shoes off, lie on the beds, and order room service. But we had all these fun things to go to in the evening that we wanted to do. So we did them, and we were glad we did them. But
yes, it was really great. We, what's so much fun about this too is getting together with our colleagues that first of us. So that was always so much fun because, we live in opposite areas of the country. So that was so fun, but also our other colleagues and friends in the menopause space and the sexual health space that, we've met via Instagram or whatnot. And so it's a chance for us to come back together and to see each other in real life, which is just so wonderful.
Yeah, I know. It's really exciting. We make so many connections online, especially. There are a lot of women involved in menopause and sexual health. And so you make all these connections online and then you finally get to see each other in the flesh. It's so much fun.
It's
and you
so
kind of
fun.
feel like you're besties and that you've
I
known each
know.
other for ages, and it's all been online. It's so funny how the
Yep.
world works now. But yeah,
Yeah, it
when you get
really
that little bit of
is.
time together, it's so special, isn't
It
it?
it really is. And just, making friendly, just new friendships and just advocacy. We're all in it for the same reason,
Yeah.
for women's health and to make sure that we're doing our part in that. And so it's just like-minded individuals and women, and we're all going through it or been through it too. So I mean, you get that part of it too, which is so great.
Yeah.
Um, Okay, well, let's get started because we got some more stuff to bring you all here.
Take it
So this
away,
one I
Rebecca.
thought
Take it away.
this one I thought was really fun, and I was just like, oh my gosh. So the history of sexual medicine was a lecture given by Dr. Sue Goldstein, and so I'm just going to go through these takeaways because I legitimately have like pages of notes in here, and we would never get through it. But I thought this was interesting. So ancient Greece and Rome. Women were basically property, no pleasure, just baby making. Meanwhile, men did whatever they wanted, right? So then there was religious influence. So medieval Christianity turned sex into a sin fest. Pleasure was off the table. No soup for you. Okay. And then the Victorian era were treatments, right? So this is like, ladies, this is where hysteria came in, and women, are you hysterical? Doctors thought massaging the uterus or inducing orgasms was the cure.
Yeah.
I don't even know what to make of that, quite honestly. So, I mean, the things that were, and you think about it and you're like, I just don't know how long ago that was. That wasn't
Not
long enough ago.
it wasn't long enough ago, honestly. And this is all men, right? Women didn't have any power during a lot of these times.
Yeah,
Um,
yeah. And
unless you're
so,
talking about a few women in ancient Rome or ancient Greece. But otherwise,
right.
this is all based on men and their need for power and
Yep.
control.
Yep. Women were
And
inferior. We weren't as
uh-huh.
smart, right? Our brains were smaller, they thought. So it was interesting to read the menopause brain and really know that the actual template brain is the female brain.
Yeah.
We are the template brain.
Yeah.
And then when testosterone goes high, then you become a male brain. So sorry. So I was like, just remember, I am the template brain. So anyways, modern game changers. Kinsey shocked the world with his research in the 1950s. Master and Johnson defined our four-phase sexual response cycle in the 1960s. Viagra in 1998 changed male sexual medicine overnight. But what about women's health, y'all? We're still fighting for equal attention, or any
Mm,
attention. Any attention would be great.
yeah.
So, it's interesting. We've come a long way, but I think, the point is that there's just still so much to do, so much in that, that quote unquote boardroom where men still feel like they kind of ruled the world, and, and that it's a patriarchal society, right? So the man
Yeah.
goes and works and the woman stays home and cleans and has babies, and, it's changing. And I think as providers and clinicians, we're teaching our women and men, if you're taking care of both women and men, young adults, that these things matter. I do think some of these things are changing. I know in my home, these things are being taught that, sexuality is equal. These are important. Your partner is important, and if it's your female partner, then their desires and their sexuality is important. And they're not just for making babies.
Yeah. It all starts at home, doesn't it?
Hmm.
It all starts at home.
Yeah,
Yeah. You can
100%.
tell when you talk to people who has and some people aren't taught at home and they self-educate, which is wonderful, but in
Yep.
general these things start at home. And so if you can just
Yep.
be open and honest with your partner and your children and teach them the proper names of all their body parts
Yes. Let's
and not
start
be
there.
ashamed of these things. Yeah,
Let's
it's a good
start
thing.
there. And for so many reasons, right? Not to be shameful. And then if God, if something were to happen to your child, they know what their body part is called. It's so
Yes,
important. So I won't go off on that
exactly.
tangent, but
Jennifer Lanoff, who is a nurse practitioner extraordinaire, did the next talk called The Messy Ethics of Sexual Health. She, in her previous life, was a public defender and then went in and did, she does women's health as a nurse practitioner. And she's an amazing person and gave a great talk. And one of the things she talked about was informed consent, ethics in medicine. So you always need to make sure that your patient knows what's about to happen and you've talked them through the whole thing. We meet a lot of patients who have been put on medications or had surgeries without knowing that these medications would push them or surgery into full on menopause, that it would affect their future cardiovascular health, it would affect their brain, and it would affect their bones and their genitourinary syndrome. And so they've been started on these medicines or had these surgeries without education, without true informed consent. And then they go through these horrendous, complications of not having their hormones, and they don't even know that they're having those symptoms because of the medication or the surgery. So we need to really do better with informed consent when it comes to women. She talked about healthcare inequalities between the LGBTQ plus community, the disabled community, and low income patients who face major barriers to care. And she talked about legal cases that shaped or are shaping medicine, such as the Yale IVF pain scandal, which is now a podcast, I believe, or podcast, I think, not a show yet. Patients were not given pain relief during their egg retrieval, which is horrendously painful.
Yes, I went through that. I could not imagine.
No.
There's no way.
No, I mean a true sociopath / psychopath.
Yes. Yeah. I mean, they are. If they don't know when they're retrieving, they're going in and getting your eggs.
It's not a quick one and done. No, it's not.
No.
It's prolonged and it's painful and uncomfortable. And so that was one case. And then the next was the Dobbs decision, Roe v. Wade being overturned, going to have a massive ripple effect on reproductive health for women. Women have died already because that was overturned, because doctors are scared to treat their patients as you should in medicine appropriately when they come in with certain conditions, because they're worried they're going to face criminal charges or be thrown in prison if they treat them as they're supposed to. So this has caused a massive, horrendous back step in women's healthcare in this country. And, it's the colliding of politics and ethics within healthcare, which shouldn't happen, but is happening.
That's right. That's right. All of that should stay out of healthcare.
Yeah. So that was a fascinating talk. Your politicians need to stay out of the exam room. In the exam room,
let us do our job. It's all it's science-based. Let us do our science-based job. We like that. All right. So the great menopause mystery, GSM and estrogen myths. So we kind of touched on this a few times. Will be, pretty quick, and I won't spend a lot of time on it. But, we know that the genital urinary syndrome of menopause affects at least 50% of postmenopausal women. I would say probably more than that. But only a fraction get treated, partly because they don't know and we don't ask. You should ask. Please ask. And you can't just say, is it painful sex? Okay. You really need to ask a lot more questions, because they may not be intimate, but it may not be because it's painful. Maybe their partner can't be intimate with them. And then, so that's why they're not. So you really need to ask the questions about, itching, burning, irritation, urinary frequency, frequent UTIs, and along with, that, dryness or irritation. We know some women can't wear underwear. We know some women cannot use toilet tissue to clean themselves because it's irritating. I had one patient tell me that what she noticed, her vaginal estrogen working because she stopped bleeding when she would shave.
Oh my gosh.
I was just like, my jaw dropped.
And these are the things that women go through. Gradually, you kind of think of them as, that's how it is now, know?
You got it. I don't even think that women are just, they're so busy and they're just like, oh, it's another thing, and they
Yeah.
just kind of carry on and like, oh,
They
blow
don't
it
say,
off.
oh, there's something wrong, I need to make an
Yes,
appointment with my doctor. They're like,
that's
oh,
right.
okay, so this is happening now. I
And
guess
and
that's how it
and
is.
that's right. And they're not being educated that it shouldn't happen.
Yeah.
Right? I mean,
Yeah.
in all reality, we're not educating that this shouldn't happen. You need to come see me if this happens.
Yeah.
So, black box warning on vaginal estrogen, we talked about many of times, scary and misleading. It should be off. We are working on that. Dr. Rachel Rubin is really a big advocate working on that as well. Local vaginal estrogen does not increase breast cancer risk. And more oncologists are now recommending it for breast cancer survivors, which is fantastic. I'm seeing that locally here, which is so great. I'm so excited. These are safe treatments: local estrogen creams, tablets, rings, DHEA, which intrarosaprosterone is the FDA approved. That breaks down into estrogen and testosterone. So does the same thing. And the point here is it doesn't have a black box warning.
Doesn't
That
have a
was a
black
good
box
point.
warning, but very expensive and hard to get
Cool. One,
covered.
absolutely.
Yeah.
100%.
Yeah.
So, why are we still scaring women away from treatments that improve quality of life? I don't know. If you have the answer, please let us know. We'd like to talk to you about that.
Yeah, I know, we really would, because they had no problem getting the message out with a loudspeaker and medical
Yeah,
journals and news shows saying that estrogen was dangerous, and have not made any of those same efforts to say, actually, we were wrong and it's not.
that's right.
So that's the part we're working on.
No,
The
they
next
just
one.
sneak them in
Mm.
with like other little articles here. So,
The next one was a funny one. Scarlett Bergman gave a talk on, can AI teach sex ed? I don't know. Do you want a little robot teaching you sex ed, or would you prefer you get it done by in person, maybe in schools?
yes.
I
I know
mean,
it was.
there's room for it. The theory was AI chatbots could revolutionize the sex education. You know, I've forgotten Roe. What are they called? Roe v. Roe. Oh, there's a little group online that pop up on my Instagram page all the time, but it's where she's out on the street with a microphone and she's
Oh,
interviewing men
yeah.
and asking them questions. And she
They're
says things to
hilarious.
them.
I love it
Oh,
when
they're
you have them
so
on, you
good.
share it.
What are they called? Is it Roe v. It's
Yeah,
Roe
I
v.
can't
Roe v.
remember.
Bro. Roe v. Bro. So she says
Okay,
things to them
yes,
like,
yes, yes, yes.
"What size is a human egg?" And the guys will be like, "Well, I think it's like this big." She'll say, "How many tampons does a woman use in each period?" And someone will go, "One, I think." Does a woman have to take her tampon out if she wants to pee? Yes, she has to take it out every time she wants to pee. Like, the sex education in this country is
It's terrible.
abysmal.
It's
Abysmal.
terrible.
So, I honestly, I'll take anything. If you're not going
Yes,
to teach it in
I'll do
schools
an AI
and
chatbot.
you're an adult who's embarrassed, you don't know anything about sex ed, could an AI chatbot be helpful? Absolutely. Do it. Whatever
Yes,
it takes. Yes, please.
I love it. I love it. I'll take it. I'd be interested. I'd play around with it a little bit.
I know. I think it could be interesting. I'm
It
open
could.
minded.
Yeah, yeah. All right, the next one, the future of sexual medicine. Sarah Pons. Key takeaways here. Patients demand gender inclusive, trauma informed care. We touched on this before. It's so, so important.
Yeah.
These are just things that I don't think, unfortunately, are just innate because we weren't taught this,
Yeah.
right? So these are things that I think as clinicians, and were you taught that in residency?
No, I was
I
not.
wasn't. So
No.
these are things that we're learning, and it's
Yeah.
okay. You need to learn about them.
Yeah.
Okay.
And I think
Um,
that actually Black women are doing a lot of the teaching, which it shouldn't be up to them. But I
yes.
think that they have had to lead the way on this, and they've
Yep.
been amazing,
Yep.
and very gracious to do it. But they are definitely the clinicians and women
Yeah.
leading the way. Yeah.
Yeah. Yep. I agree. We need more diverse sexual medicine providers. Patients want doctors who get their experiences. 100%. You have to be able to, relate to your patients and to talk to your patients, especially about sexual medicine. Remember, it is not just a heteronormative that is out there. As a matter of fact, I'm always asking about partners. How many partners? Are you
Yeah.
open relationship? Are you close? And people look at me. I'm like, there's no judgment here. I just need to
Yeah.
know.
Yeah.
Because this is important. This is, patients have one partner, two partners, three partners, sometimes multiple partners. So these are things that, are happening, and clinicians need to be able to take care of these patients.
Yeah.
And
I mean,
so
the more partners you have, you could be increasing your risk of getting
yeah,
pregnant, which is a very
yep,
difficult and dangerous time for women in their lives. And
yep.
then you're thinking birth control, you're thinking STIs, sexually
STI.
transmitted infections.
Yes.
Yeah.
Yes. Yeah. And not just that, but, sometimes it's also, you know, a chance to talk about even just therapy too, or to make sure that both partners are on board with what is going on in
Yeah.
their intimate relationship. Are both partners okay with an open relationship or a closed relationship or more than one partner? Is someone being coerced to do it, and they aren't giving permission? So these
Mm.
are times, to make sure that you're asking these, you can ask these questions.
Yes.
Can we talk about your sexual health? So medical schools barely teach sexual health. I will tell you, that is right. However, I was at a round table at our local medical school. That's my alma mater. My oldest daughter is a second year student there now. And we did have a big, and when I think round table, I was like, oh, just a little like
I know,
50.
10 people. Yeah.
I walk
Yeah.
in
That's not what
to my
happened.
old lecture hall, which holds like, I don't know, 150. And I'm like, like my jaw drops. I looked at my girlfriend colleague and I was like, oh, this is big. She goes, oh yeah, it's real big.
Oh my
I'm like,
God.
okay. So, but it was nice. And I was really excited to see that it was at least a conversation that we had. It was 2 hours, I believe. And yeah, 3 to 5. And it was great. And I really tried to bring in more of like the perimenopausal and menopausal sexuality idea and point of view, I guess. So that was really interesting because we didn't have that. And so, but it was just, it's at least a start, because I don't remember having that. I mean, it was a long time
No,
ago, but I don't remember it.
I know. Do you find that when we go to something or we are part of something, hosting something, like you and Christine and Dr. Heather Quayle and I and Dr. Simpson put on a women's health talk for the DOD a few weeks ago.
Mm-hmm.
And we were told that the number of people who registered for that event was so much higher than other events that had been held before. And every
Yeah.
time we do something or we're at something, we hear that same message.
It's
Like,
so great.
finally starting to get
It
somewhere.
is. It
Yeah.
is. It's so exciting, this space, because it's exciting that clinicians want the
Mm,
information, and not just
that
clinicians,
is.
women too. And not just women, but their male partners want it as well.
Yeah.
They really do. So that's starting, that's trickling in a little bit more. But the fact that
Yeah.
these clinicians are just like, we want the information, I thought it was just fantastic. It was so
I know.
exciting to be a part of that.
I remember giving a talk to a big group of doctors and being so worried about it before it that they were going to be waving papers in my face and accusing me of lying and getting the information wrong. And that was the complete opposite to the actual experience. Everyone
Yes.
had their hand up. Everyone had a question. They wanted more information. What about testosterone? How do you dose it? How do you give it? Like, just things I was really not expecting, and
Yes.
just made my heart so glad.
Isn't it great?
Yeah.
That's been my experience with a couple lectures I've done for the local family medicine, like lunch and learns.
Yeah.
And every time I've given it, they're like, "We want you back. We want to go over this again. This has just been amazing." It's so great, and we're really, we're want the information. They want the information. And I love seeing that because, we want to give it.
I know. It's really exciting. It makes you feel good, like you're on the right path.
Yeah.
Sarah
Okay, moving on.
Gave a talk about, is lactation ruining your sex life? And I think, we have a term for the GSM, genitourinary syndrome of menopause, which is when our hormones drop during the menopause transition. But then we forget about other times in life where we have a lack of hormones as well, like when we're on the birth control pill sometimes, or when we're breastfeeding, lactating. So we can really be missing our hormones during that time. And a lot of women will have a lot of vaginal dryness and vulvar symptoms during that time that is not picked up on.
Yep.
And so in Ireland, when you have a baby, you are discharged home after a couple of days, and you're given on your way home a note to say when the nurse will be at your home to check on you, usually a few days after birth. And the nurse comes to your house, weighs the baby, checks on you, sees how everything is going, and then makes another follow-up visit for you another couple of weeks later. And so you don't have to take your bleeding vagina and try and get into the car carrying a baby carrier and get to a hospital appointment to see your doctor. You can stay at home where you're safe and comfortable, and they come to you and check on you. And so this type of thing is picked up on. Here in America, we say to women, off you go now with your brand new baby and your bleeding vagina and your torn perineum, and we'll see you in 6 weeks. And then we'll give you a checkup and we'll say, good on you, girl. Now you can have sex again because you're 6 weeks out. And you're like, oh my God.
No, thank
what
you.
What's happening? I can't even sit.
Right.
This is hell. So we miss all these things, especially in women who are lactating or having or breastfeeding. And so, some of the clinicians are now trying to rename this period the genitourinary syndrome of lactation, GSL. So it's that postpartum sexual dysfunction, vaginal dryness, and pain. And it's because you're missing your hormones, because you're breastfeeding and they're being suppressed. That's why you're not having a period. And most women don't talk about it. And we think up to about 74% of women have sexual dysfunction postpartum. So that's a massive percentage of women. Going missed. So treatments again would be to give a woman back her hormones. So you probably may not want to use like you normally would a menopausal hormone treatment, but you're going to give them back locally where they're needed. So with estrogen cream or estrogen testosterone cream or the DHEA and some pelvic floor physical therapy, and your patient is going to really bounce back and feel so much better and not feel like there's something wrong with her. That this is normal, to let her know that 75% of women go through this.
It's crazy,
Yeah.
And they're probably, I know. Well, I think there's so many other things going on, like you said. And I will tell you, I don't know if it was with my last one, but I did have, and maybe they've done away with it before, but maybe it was my older kids that are adults now, where I had the nurse come in. I did have a nurse come in. Yes.
That's
because
unusual.
I was just like, I don't know what I'm doing. Like, I don't know what I'm doing. I don't know how this baby latches. And maybe it was more for lactation.
I paid out of pocket.
Came in and did all that.
I was having so much trouble. That I paid out of pocket to have a lactation nurse come to the house and see me. I was like, I'll pay anything. I just need help. No one, I was a doctor. I delivered hundreds of babies by this point, and I had no idea that breastfeeding could be excruciatingly painful. I had no idea.
100%.
Women don't tell you because they think they're failing. They think they should be.
Or they think it's normal.
Rainbows and roses.
Complain about it.
Yeah, exactly. And so we have all these women out there who think there's something wrong with them because they're finding breastfeeding painful, not knowing that almost every woman finds it painful because we've been faking it until we make it.
We've been faking it between that, the painful nipples and the uterine contractions with it. That was awful. I was like, oh my, I would just clench every time I had to feed the baby.
Talk about being kicked
for me, it was just awful. It was labor pain all over again. So it's crazy.
It can be hellish. I mean, women are to feel like you can't even tell your own doctor about it. We need to change that. Yeah, we need to be
Yep,
asking the
because we feel
question.
like we're failing.
Women won't volunteer that information. They'll keep it to
Nope.
themselves. You have to ask. And to ask, you have to have the time. You know,
Yes,
so we're
you
back
do.
to the whole system needs to change, unfortunately.
Yeah.
How
Don't
about the
get us
next one?
started, guys, on our soapboxes here. It makes for a long episode. You have to put us on 1.5 to get through it.
I know.
Yeah. So, all right. Next one, pelvic pain, couples, and therapy. I touched on a little bit of this. This Rose Hartzell it was great. Really talked about sexual dysfunction affects both partners. So, and it's so true, you know, like when one person is having sexual dysfunction, it really can and often affects their partner as well. You know, whether they get upset or they feel bad, they're scared to touch them, or they're feeling like they don't love them enough. So whenever some common bad partner reactions would be the overprotective partner that says, well, let's just stop having sex. The dismissive partner who says something like, well, it's just not a big deal. It's fine. And then you do have a supportive partner, right? So this is obviously the best approach. These are the partners that are like, we need to work through this together. We're going to do this together. Let's go to therapy together. I'm going to support you. You're going to support me. This is a partnership. And so sex therapy, we touched on this before, sex therapy and medical treatment gives you the best outcomes. They really do go hand in hand. And so, and I think that we don't talk about this enough when we're even just asking if you're female patients about if they're having sexual dysfunction, how is that affecting their female partner and female partners, and how it's affecting their male partners. And then to say, hey, what about therapy? We have to break the stigma that therapy is bad when it comes to any type of therapy, but in particular, I think sex therapy.
Yeah, that was a really interesting talk. I just think it's not that topic's not talked about an awful lot. So I
Nope.
think everyone really enjoyed it.
Yep. All right.
Oh my gosh, the next one was
This is great.
oh my gosh, Rachel Rubin's talk on
On testosterone.
testosterone therapy for women. It was so funny. Oh my God. We all got a great laugh out of that.
We really did.
I think her point, kind of like we said in the last episode, was why is it so taboo still for women? Testosterone is a hormone that we make every single day and have since we were in utero. All our estradiol comes from testosterone. And all any of us are saying is we want to treat women who have low sexual desire disorder with testosterone. But when we do, we also see them come back and tell us other things, that it really helps their brain, really helps their energy, and it also helps them build muscle. And we're not talking bulking up here. We're just talking about women who go through this thing called sarcopenia as we're going through the menopause transition, where we lose a percentage of our muscle mass every year. And it tends to get replaced by adipose tissue, fat,
which is, less metabolically active.
Away. Yeah. And so we try and we eat our protein, we do our muscle strengthening program. And a lot of women don't make any progress in that. They might be able to stay kind of stable, but they can't make things better. And then they'll find that when they start on their testosterone for their hypoactive sexual desire disorder, they come back and they say, do you know what? I'm finally able to build muscle.
Yeah.
When I've been putting all the work in and I haven't been seeing the results, and now I'm seeing the results. So Rachel Rubin's point was, we can't just ignore that information. Yes, we don't have the studies. We need the studies, but we could all be dead before we get those studies.
Yes.
So medicine is a science and an art. We can't just have those in their ivory towers saying, I've done all the research on this. You can only use testosterone for this issue. While all the rest of us, boots on the ground, clinicians,
are seeing. It's like gatekeeping, right?
Yeah. What are we supposed to do? Just ignore what patient after patient after patient is saying to us? Just ignore that. That, medicine didn't start with research. It started as boots on the ground, taking care of patients. So we can't just forget half of the whole premise of medicine, right?
That's right. That's right. Yeah. And I've seen it. I experienced it and have seen it, as I was really 45 was a turning point for me. 45, 46 for sure was a turning point where I started to notice that sarcopenia and, and where I could lift heavy, but when I did my workouts, I wouldn't have to work every body part. So that is a transition that I've had to make now. My muscles only respond to doing a full body workout those 4 days a week. Now I might work legs a little harder or arms or whatever a little harder, but I could no longer not work them all out. And it was it was the craziest thing I had ever seen. And that's not everyone. And I tell my patients that. So I offer them those two different, a couple different things, but I tell them that I'm like, it happens. I've seen it all of a sudden, my definition and tone was just not there. And I was still doing all the same things. It was just crazy.
It is. And you feel like you're going crazy because you're
because you're like, is this really happening? And my husband's like, no, I see it. Like your muscle definition is not there. And that it was there last year.
Yeah.
So
yeah, it happens fast.
It does. That was the scary part for me, was like, holy cow, that happened fast. Like, what are my bones like?
Exactly, because it's all connected.
Yeah. So that is important.
I'm jealous that you get to do the next one. Go on.
I almost want you to do it because I think you could do far more justice than myself.
No, we'll talk about it after.
I was going to give it to you because you are just do the absolute best with Dr. Blooming, and and I know you loved that lecture as well.
Can I just ask what? It was just unbelievable to sit there and be in the same room with him giving that talk. Like, I just wanted to freeze time because we've been on Zoom with him and stuff, and had lectures and whatnot, but it is not the same as being in the room
when he gives a lecture.
He is a fucking legend.
It's the second one that I've been able to be in the room. The first was the Swell event.
Right. Yeah.
And
I miss that.
And Carol Tavris. And I was just like in awe. I'm like, just talk for the whole time. Don't let anyone else up there.
I know. I just did not want it to end.
No, it was amazing. I love the enthusiasm. I love it all. And so,
for anyone listening who doesn't know what we're talking about, this is Dr. Avram Blooming. He is a medical breast oncologist who that's been his whole career. And he's very open about the fact that he was quite closed-minded earlier on in his career, convinced that estrogen caused breast cancer. And then as he moved through his career and learned more and more and more, he does a lot of medical reading and a lot of research, realized that that was actually not true. Yeah. And that when you look at all the studies and you look at all the results, what they actually show is that estrogen seems to be very safe on the breast tissue. Yes. And so he has made it his life's mission, along with Dr. Carol Tavris, who's a PhD in social psychology, who's a genius herself. The two of them came together and wrote this book, Estrogen Matters, that we ask every one of our patients pretty much to read, don't we? Yeah.
Yes. And you can get it on Audible if you don't have time to read, and listen to it on Audible. And it's fantastic.
Dr. Tavris reads it and she's so good. Like, she's like spicy and snarky, and I love her.
She was the best lecturer. I was just like, I loved it. I absolutely loved it. So witty and just, it was a lot of fun. And so she wasn't there, but Dr. Blooming was, and again, talked about exactly what we just spoke about. The black box warning on estrogen is outdated and misleading, that the, estrogen and breast cancer, that conjugated equine estrogen is actually protective against breast cancer. And, why are we still talking about this all these years, later? And that, reduces mortality as well. So not only is it protective, but also reduces mortality. And again, we talked about the it's not use prevention of cardiovascular disease, but we know that 10-year window started within the first 10 years of menopause, that it can be protective in, not just cardiovascular, obviously your bones, and your bones throughout. I tell my patients it's not just those first 10 years, but we do want to protect you, because that late perimenopause into menopause is when you have the most bone turnover.
Yes.
So we want to prevent that, but, in your brain health as well. So it just was an incredible lecture with all of the WHI people.
I'm just trying to Google something here to see. Do you know what was one of my favorite things? I have heard, his stories are legend, right? About the Women's Health Initiative. But I've heard him say a few times that not long after July 2002, when the investigators of the WHI, a small group of them, came out and said publicly that estrogen caused breast cancer. Not long after that, Dr. Blooming invited one of those investigators to give a talk at his institution. And it was either halfway through the talk or after the talk, one of the doctors there listening said, could I ask a question? And asked a question of this person and said, how did you come up with those numbers? I mean, they don't make sense at all. When you look at the numbers, they show that there was no increased incidence of breast cancer. So how did you make the decision to say that there was a connection and to write an article for JAMA, one of the biggest medical journals at the time, and come out and do news shows about it? And this person said, well, when you want a result and the numbers you have aren't adding up, you have to get the statistical police to leave the room. And I have always wanted to know who that was.
I know.
And Dr. Blooming told us in this lecture. It was Rowan Chabowski. I knew it. I needed confirmation.
You knew it.
Confirmation.
Aoife was like dying.
I just think there's a whole pile of them that should be behind bars.
Yep.
They have been complicit in the death of just an incalculable number of women. And not just death, but sickness. And, loss of joie de vivre, like just, women being able to be themselves, and have caused this utter decimation of women's healthcare over the last 20 years because they chose to do that.
Yes. The loss of marriages, the loss of, and I should say relationships, the promotions not taken, the amount of,
leaving the
workforce, the amount of money spent on antidepressants, on the women that were, put in mental institutions, or that took their lives because of the changes in the brain that can occur during this stage, and I could not have been one of those women like 10, 15 years ago. I could not have functioned. There's no way.
Yeah, me neither. I'd be curled on the floor in a ball. Without
I'd be useless.
Yeah. I know that for a fact because I was there.
Yes, that's what
I'm not imagining it.
That bit of time before, I'm lucky enough. I chose hormones. I didn't have any contraindications. And I wouldn't be sitting right here right now doing all of these things and being productive and being a good partner and mom and, all the things that I want to do.
Yes.
That's for sure.
So that was amazing.
Yes, it was.
Very much
we fangirled a little bit.
I know.
And we didn't get a photo. I don't know how that happened, but anyways.
No, I don't even care. The photos mean nothing to me. The fact that I was in that room with him, those memories are what matters to me. Yeah, it
was great.
It was so good. I loved it. And then the last one that we were going to talk about was Erwin Goldstein gave a great talk about the orgasm debate. And how it's neurological, hormonal, and a psychological experience. So a big mixture of things. And disorders exist, and he gave a really complicated and interesting talk on how it works.
Yes, it was It's a
I
lot.
still have to wrap my brain around
So
it.
do I. That's
I
probably
know.
one I'll need to watch like 2 or 3 times.
Yeah. So there's like two systems. There's your acceleration system and your braking
Hmm.
system, and they actually both have to be little properly
Yes. So
for you to orgasm
go,
properly, you know.
go,
And
and
if
then go.
one is a little bit too much or too
Yep.
little, then things aren't going to
Doesn't
work
work.
properly. So it was really interesting. And it just goes to show how little we all know about the process.
Yes.
Yeah.
Yes. No, and it's really interesting some of, the how people can feel afterwards, right? Like you were talking about not, some people having migraines, some people put them to sleep, some people have flu-like symptoms afterwards. And so
Yeah.
really, and some are
Really
just like, okay, I'm
interesting.
going to go wash the whole entire house now.
I know. He's a cool man as well, isn't he?
I know.
So
Yeah. Yeah.
interesting. We got to
Yes,
talk to him a little bit
we did. That
at
was a
one of
lot
the
of
evening
fun.
events. Yeah.
Hmm.
Yeah. It feels very special to be around the goats of
Yes.
menopause and sexual health like that, doesn't
Yes.
it? Yeah.
Yes, it really does.
Yeah. And we're very
I
lucky. We
really,
have friends and colleagues who are
yes,
so kind and so welcoming and have introduced
yes,
us to these clinicians and um, other, big players in the field and just have been
yes.
so welcoming.
So welcoming that I was
Yeah.
going to say the same thing. We just, this happened at the Menopause Society conference and now at the Ishwish conference. Just, wonderful people that, had shared their experiences with us and want to bring us in to share experience and to build new experiences. And we've just been
Yes.
really grateful for that. And, it's the importance of camaraderie, is it's really important. And it's important to move forward in educating and advocacy. We need to work together in this space. So I
Mm.
appreciated all of those opportunities.
And for women being 50% or 51% of the population, this
Yeah.
shouldn't be a niche area in medicine, right? It should be like one of
Correct.
the biggest areas in medicine. But
Yes.
it isn't. It's a real niche area, and there aren't that
Yeah.
many clinicians involved in menopause and sexual health in
No.
this country. And so you would think that trying to be a part of that, there might be people trying to keep you out or
It's so
or not
weird, isn't
welcome you.
it?
And it's not like that at all. No.
Yeah. Yeah.
Yeah. It's
Exactly.
been wonderful.
It's just we've
Um,
been just really, really wonderful, wonderful colleagues.
I know, very, very lucky. And long may it continue. I was
Yes,
putting
same.
together some final thoughts there
Yes. The
as
O'Sullivan
we were going
thoughts.
through. Um, uh,
The Aoife takeaways.
I came up with probably three, maybe. Number
Yeah.
one being the importance of informed consent. So
Yes.
I think this goes for anything in medicine. If you're going to have a surgery or you're going to have be started on a new medication, don't be afraid to ask, okay, what are the potential side effects of this? It's not that I'm not going to do it or take it, but I really want you to go ahead and give me worst case scenario because I
Yes.
want to go in with my eyes open and I don't want any shocks and frights down the road. Like, just give it to
Hmm.
me straight. I think patients
Hmm.
deserve that, right? And then they
Yes, they
can
do.
decide with that knowledge what to do. But
Yeah.
if you keep some of that from them, then that's not really true informed consent.
That's right.
Yeah, and
That's
women
right.
are suffering because of that.
Yep.
The second
Yep.
one I would think would be the genitourinary syndrome of menopause and the myths surrounding the vaginal estrogen cream. It's really safe. We have studies up the wazoo on this.
Hmm.
Using your vaginal estrogen for a year is about equivalent to having one or two birth control pills
Yep.
that we normally take every day. So the
Yep.
quantity in there is just tiny, and yet it will save you from massive complications down the road.
Yes. And a lot of
Um,
money.
the Dusty Muffins think that every woman should be sent a tube of vaginal estrogen on
Yes.
her 40th birthday to keep in the cupboard for
100%.
when it's needed.
Yes.
Hopefully, someone from a government health agency is listening to that. And then just to remember, there is such a thing as the genitourinary syndrome of lactation.
Yep.
And I'm going to stick in there like being on the birth control pill too.
Yes. Oh, good. Good. I was going to say that.
Any situation where your hormones are low and you're having symptoms as if you're going through menopause,
Yes.
don't keep it to yourself. Do go and
And
talk to your clinician about it.
yes.
And like we said in our
And
last episode, get a mirror and look at your vulva and see
yeah,
what's going on there.
yes. And clinicians, I'm just going to add, they need to educate about that. When you are putting these young women on birth control pills, and that's fine, but you need to tell them all the things that could happen, because they may just think it's normal. Most of them think that nothing should be dry, when in reality, that's not lubrication for everyone. Lube for everyone. I don't care what age you're intimate. Lube for everyone. Okay, guys, it just makes things so much better. So it's not just for older women.
Absolutely.
And these younger men need to stop thinking that if a woman isn't lubricated, that means that they're not aroused. And that's just not how things work, So some have abundance of lubrication and some just don't. And so all of our anatomies are different, just like your male anatomies are different. And so use lubrication. It's fun. It's okay. So,
yep.
And clinicians, make sure that you're educating on that when you're starting them on pills and when women are breastfeeding.
Yes, that's great.
So,
hormonally.org, we mentioned in the last episode as well, is a free website with loads of education about this as well, that we just learned about at Ishwish.
Yes,
so,
I know. I've got to write that down again.
Yeah.
Yep. I'm glad you remembered that. And that was the last of the key takeaways?
That was it.
Okay. All right, Dusty Muffins, that's a wrap. Keep advocating for your sexual health and don't settle for bad info or outdated medicine. Until next time, stay curious, stay empowered, and keep the conversation going.